over an hour. Okay, so we'll define what a seizure and epilepsy is, the difference between seizure and epilepsy, differentiation between seizure and syncope. Very important because syncope is often a seizure mimic. Common epilepsy syndromes, especially in adults and adolescents and adults. Causes of epilepsy in adults. Whatever investigations that we would generally do for a patient with epilepsy, and principles of management and psychosocial support in epilepsy. And we will also touch a little bit about epilepsy in women as a special group that we would that needs consideration. Okay, so let's start with first. Okay, so what's a seizure? A seizure is a set of clinical symptoms, right, that are a result of abnormal electrical activity in the brain or electrical activity in the neurons of the cortex of the brain, right? And the clinical characteristics, or what we call, there's a special word that we use, is semiology, especially in epilepsy. It's very synonymous with the symptoms and the signs that one would have when experiencing a seizure. Is the word that we use is semiology, right? And these clinical characteristics depends on which part of the brain is actually stimulated. For example, if the seizure affects or is a result of stimulation of say the motor cortex, what would the manifestations of the seizure look like or sound like, or what would the patient experience? Can someone tell me? It's a very simple question, a simple answer. Anyone?
So they will have primarily motor symptoms.
That's right, correct. So they will have motor manifestations, right? So if it is, say, for example, if it involves a sensory cortex, then they will predominantly have sensory symptoms, right? And if it's a visual cortex, again, visual symptoms, right? So the clinical characteristics or the semiology depends on which part of the brain is affected. And how much of the brain is affected, and so on and so forth, right? So that's a seizure. And the difference between a seizure and epilepsy is a condition in which you're more likely to have seizures. These are seizures which are unprovoked. Now we'll talk about provoked seizures and unprovoked seizures in the next few minutes. But the difference is that the patient with epilepsy is more likely to have more and more seizures, right? So it's a whereas seizure is a singular event, which is a result of abnormal electrical activity in the brain. I hope you understood the difference. Now, what do we mean by a provoked seizure? So before we talk about unprovoked seizure, we should know what provoked seizures are. So provoked seizures are seizures that are as a result of transient decrease in the seizure threshold, and whatever that caused that, once you actually correct the the insult, the patient does not get further seizures, right? I hope you understood the concept. So, for example, there are certain metabolic causes. Now, I've mentioned a few in this slide, that once the metabolic insult occurs, the patient gets a seizure. But then once you correct it, for example, if you have, say, hypoglycemia, right? Hypoglycemia can cause a seizure, right? But once you correct the hypoglycemia, the patient does not get any seizures unless the hypoglycemia continues. I hope you understood the concept, right? So these are some of the examples for provoked seizures. For example, fever. Does anyone know in childhood what kind of seizures they would get if a patient gets fever and seizures?
Paralysis.
Exactly. So febrile seizure is one of the best examples that one would give for a provoked seizure, where if you once the fever comes back to normal, the patient does not get any seizures. Okay. Again, infections. Say for example, meningitis. You can have fever. Seizures associated with meningitis or meningoencephalitis, for that matter, uh, where you get seizures as a result of direct invasion of the virus or the pathogen into the brain, or indirectly due to the immune reaction of the virus or the bacterium or any other pathogen affecting the brain, can result in a seizure. However, once you clear the pathogen, or once you treat the pathogen, when the pathogen is eliminated from the body, patient does not get any seizures. So that's a provoked seizure. Okay, head trauma, hypoxia, hyponatremia, toxins, cardiac arrhythmias are all examples of provoked seizures. Okay, so what do we mean by unprovoked seizures? Anything that basically any seizure that comes on spontaneously, and if we don't treat with long-term, say, anti-epileptic drugs, this patient is more likely to get more and more and more seizures. Okay, right. So this is the operational definition. So anyone can stop me and ask me any questions if they didn't understand the concept. Okay. So this is the clinical definition laid down by the International League Against Epilepsy. So if a patient uh, develops 2 or more seizures, which are 24 hours apart, which are unprovoked, then this patient is called, or is identified as a epileptic or patient with epilepsy. Okay, so this was the definition, this is an age-old definition. This has been there for several decades, and this has been the practice, and this gives us a guidance to when to treat these patients. So if a patient comes with 2 seizures which are again unprovoked, so you need to look for a possible etiology. Say for example, if it was due to hypoxia or hypoglycemia, hyponatremia, fever, or infection, then we don't class them as patients with epilepsy, but they are patients who have had a seizure due to a reversible cause. Okay, but if you didn't have that, if the patient came with an unprovoked seizure, then and if you had 2 seizures 24 hours apart, then you are more likely to be dealing with a patient with epilepsy, and the patient will need long-term anti-epileptic medication, right? So that's the first one. Then there is also we also now have incorporated uh, uh, the sorry, the into the definition, where if even with a single seizure, now we are able to diagnose epilepsy, for example, and if the so what we do is we calculate the risk, right? Risk of recurrence even after a single seizure. If a patient has a risk of more than 60% over the next 10 years of getting a seizure, that patient can now be diagnosed as a patient having epilepsy, right? Now, just to give you an example, if a patient has had a stroke, right, and say due to a middle cerebral artery occlusion, has a stroke, maybe has right hemiplegia, and then after a few months, the patient develops a seizure which is attributable to the scar that has formed, or the scar tissue that has formed as a result of the stroke. That patient is, we will class that patient as a patient with epilepsy. Why? Because that patient's risk of recurrence of a second and a third and a fourth seizure over the next 10 years is as high as 70%, right? And that is based on on data that we have collected over a period of time, right? So in that patient, we will diagnose this patient as epilepsy and then start them on anti-epileptic drugs. So even a single seizure is enough for you to diagnose epilepsy. Now you will ask, okay, isn't stroke a provoked cause? Because if there is an acute insult in the brain and that goes away, uh, uh, could it not be a provoked seizure? Yes, there is a time period in which we consider a patient as having a provoked seizure due to a stroke or a traumatic brain injury. For example, if the patient develops a seizure within 1 week of a stroke or a traumatic brain injury or any insult to the brain, then they are more like, that is a seizure that's in the definition is by definition is a provoked seizure. But if the seizure occurs later than 1 week, those patients who have got either stroke or a traumatic brain injury, those patients are classed as patients having an unprovoked seizure. And that is not directly due to the brain insult, because we assume that after 1 week, the effect of that brain insult would have gone away. I hope you understood the concept. So there is a time frame. Say, for example, just because someone had hypoglycemia, say 3 days ago, or 4 days ago, or 5 days ago, and has a seizure now, that seizure cannot be is not attributable to the insult that occurred 4 or 5 days ago. So if it's a metabolic insult, it's generally within 24 hours of the onset of that particular insult, metabolic insult. And if the patient gets a seizure, then that seizure is attributed to the insult. That is, if it is a metabolic cause. But if it is, say, for example, a stroke or traumatic brain injury where there is direct injury to the brain, either directly or indirectly via virus or a pathogen, and that person develops seizures within a week, then that is classed as a provoked seizure. Whereas if the seizure occurs after 1 week, then we do not consider that as a direct result of the insult to the brain. I hope you understood the difference. So if a patient with stroke gets a seizure maybe 2 or 3 weeks or even a month or two after the acute insult, we then say that this patient has got an unprovoked seizure, and that the fact that he had a seizure that is attributable to the scar tissue that is formed as a result of the stroke, that patient has a high risk of seizure recurrence, and that recurrence risk is more than 60%. And therefore, we diagnose that patient as a patient with epilepsy. Okay. Then also we come to the diagnosis of epilepsy syndrome. So we talk about epilepsy syndromes later on. So the idea is that now the difference from before 2017 and now, not 2014 and 2010. Yeah, so it's about 10 years that the definition has changed. Is that now, even after single seizure, now we are able to diagnose epilepsy. Okay, so these are the cellular mechanisms of seizure generation. So in the brain, we have two types of neurotransmitters. Basically, there are excitatory neurotransmitters and there are inhibitory neurotransmitters. The stereotypical example for an excitatory neurotransmitter is glutamate as well as aspartate. And the typical inhibitory neurotransmitter that is prevalent or is common in the brain is GABA. Right? Now, what happens in the normal state is that there is a balance between excitation and inhibition, right? There is a slight propensity towards inhibition, right? Where the GABA has a slightly higher effect. So this is kind of balanced during normal function, right? But what happens during a seizure? there is greater excitation, and the scale is tipped over towards excitation, and there is a reduction in inhibition. So what happens? Glutamate concentrations, aspartate concentrations increase, causing increased excitation, and there is a decrease in GABA, increasing the level of inhibition, right? Okay, sorry, decreasing the level of inhibition. So this is this imbalance is the cause for of seizures, right? So this is the International League Against Epilepsy, or ILA, in 2017 classification. Now what they do is, now all seizures are generally categorized. I'm not talking about epilepsy, I'm talking about the seizures. So seizures are often categorized into three broad categories. That's focal onset seizures, generalized onset seizures, and if you can't identify whether this is focal or generalized, we put them into a unknown onset category. Okay, so that's mainly the main categories. And again, focal onset as well as focal onset seizures are again categorized into seizures with retained awareness and seizures with impaired awareness. And they may have uh, motor manifestations, or they may not have motor manifestations. So therefore, if the patient has motor manifestations, they will have focal onset epilepsy with motor onset. And focal, or if they don't have, they'll be having patient seizures with focal onset, which are of non-motor onset, right? And these are the examples that I have given, right? Generalized onset ones are the ones that are more likely to be familiar with, and they are the motor ones is the are the ones that you probably know of. The stereotypical example for a generalized onset motor seizure is that of a tonic-clonic seizure. We'll talk a little bit about tonic-clonic later on. Then, of course, clonic, tonic, myoclonic, myoclonic, tonic-clonic, and myoclonic atonic. All these are examples. So you just go through the slide. I think you have shared the PowerPoint, and it's, I think, available on your LMS. Not going too much into detail into the classification, but this is how we generally classify. Why is it important for us to classify the seizure? Is because it has direct bearing on the management of or treatment of patients with epilepsy, right? We'll talk a little bit about that in a little while. But when a patient comes to you, you need to basically classify these seizures. So first you decide, okay, is this a seizure in the first place? Then you decide, okay, if it's a seizure, is this epilepsy or not? Then that's why we need to know the definition. And then once you decide, okay, if this is epilepsy, what kind of seizures are these, right? Are they focal onset, generalized onset, or whether these are of unknown onset, right? Because your treatment or your management of these patients depends on that piece of data that you gain from the patient by taking a history. Right. Okay. So now, as I've suggested, broadly we have two types or three types, but the unknown onset we are not talking about. These are patients either who have focal seizures or generalized seizures. Focal seizures are seizures that are restricted to one hemisphere, right? They originate from a network which is from one hemisphere. Right? However, they may rapidly sort of progress and spread on to the opposite hemisphere, but they are often consistently originating from one or two or whatever parts of the brain which is confined to one hemisphere. And that's the difference between focal seizures and generalized seizures. We talk about, so focal seizure since they start from one part of the brain or a single hemisphere, the symptoms or the signs that these patients have depend on which part of the brain is stimulated, as I've told you before, right? So if you have a focal seizure originating from the motor cortex, right? This is the motor cortex, and it affects, say, the hand. You will have clonic movements of the hand or myoclonic jerks of the hand. And if it starts spreading, so often seizures don't stay in one place, right? They spread. And if it spreads along the motor cortex, then you will have propagation from starting from the hand. Then if it spreads downwards, right, it might affect the face, right? Or if it starts from the face, it might spread to involve the hand, then the trunk, then the hip, then the leg. And that particular seizure is called a Jacksonian march pattern. It starts from the face, spreads to the hand within a few seconds, then within a few seconds spreads to the neck, the trunk, the hip, and then and if it involves the leg, which is the mesial or medial aspect of the hemisphere, then the leg also gets involved. So that's called a Jacksonian march pattern, right? If it involves the more sensory cortex, right? Again, if it involves a face, you will have a feeling of numbness that spreads from the face, then the hand, then the arm. So you will have what's called a sensory aura. You will not see it, but the patient will perceive it. So you need to ask for it, right? If the focal seizure involves, say, the temporal lobe, right? What kind of manifestations would they have? Say the medial aspect of the temporal lobe. Can anyone tell me?
They will have features like auditory hallucinations.
Correct, yeah. So you see, so that is the lateral aspect of the temporal lobe. So if this is called the Hesher's gyrus, right? Which is involved in hearing, yes, they will have an auditory aura. Now, we use the word aura, right? Aura is something that the patient experiences. We do not see it, but the patient comes out with it, right? So if it is a non-motor manifestation, often patient experiences it's through the history, right? So you need to when the patient tells you, you need to identify them as auras, right? So if the patient will have an auditory aura, that's absolutely right. So they will have an auditory aura, and then what happens? Often the patients with as I told you, seizures are generally not they don't limit themselves to one area. It propagates it, and that is a characteristic of a seizure. And if it involves more or less the temporal lobe, they lose awareness, right? So then, as the seizure propagates, they lose awareness. So typical seizure with a hearing or auditory aura will have an auditory aura, say a buzzing sound in one ear or both ears, and then the patient loses awareness. And as it spreads, it also incorporates the frontal lobe, right? When it involves frontal lobe, then you will also see motor manifestations, right? And these motor manifestations are complex motor manifestations which mimic normal activity, right? And those are called automatisms. Say, for example, they may have what we call oral automatisms. They might have swallowing movements, right? Or they might have lip smacking, like sucking. They might be, mimic like sucking sounds. They may make sucking sounds. Uh, they might, uh, have what we call gestural automatisms, where they might pick at things with their hands, or they may mimic what they were doing before. Say some people just continued doing whatever they are doing. So those are complex tasks. But if you talk to them, they have no awareness, and then they come out of it, right? So those are complex tasks which mimic complex motor tasks. They are called automatisms, right? And if it involves the hands, they are called gestural automatisms. If it involves the mouth and the area around the mouth, they are called oral automatisms, and they are very typical of patients with uh, temporal lobe epilepsies. Okay. Uh, Medial aspect of the temporal lobe, what are the functions normally of the temporal lobe? Does anyone know? So if you have a good idea on functional neuroanatomy, you will be able to basically localize any focal onset seizure, right? Because you just need to know what area does what. Right? So if the patient has a seizure originating from the mesial aspect or a medial aspect of the function of the temporal lobe, what kind of manifestations would they have? So now we spoke about the lateral temporal lobe. What about the mesial aspect or the medial temporal lobe? What are the functions? Does anyone know?
He may have altered taste sensation.
Yes, correct, absolutely. Because the entorhinal cortex lies close to the mesial aspect or the medial aspect of the temporal lobe. So they may have altered taste, absolutely, right? So they will have an gustatory aura. It's called a gustatory aura. Anything else? Sorry, that's the taste. Smell? So an olfactory aura. So they may have olfactory or gustatory auras. Anything else?
Memory problem.
Excuse me. Sorry. Hello. Yeah. Morning. Oh. Oh. මම නම් මේ දවස්වල බලන්නේ නැහැ patients. නෑ නෑ. මොකද? නෑ නෑ මං කියලා තිබ්බ මේ සතිය නෑ කියලා. එන්නේ Sunday. නෑ. Okay, right. Sorry, yeah. So you can have an olfactory aura, you can have a gustatory aura. What else? Does anyone know about the limbic system? What does the limbic system do? Anyone?
Emotional responses, sir?
Exactly, yeah, absolutely. So one of the main components is the amygdala. So amygdala is, if you all are not aware of where the amygdala is, go home. Read where it is. So it's also one of the structures which are involved in generation of fear. Okay. So if a patient has a feeling of fear, right, and then loses awareness, has gestural or oral automatisms, then we localize those seizures to originate from the region of the amygdala, and then as it spreads to involve other structures, then they lose awareness, and then as it spreads towards the frontal lobe, then you have these complex automatisms, right? Oral or gestural automatisms, right? So the concept is clear, I hope. So if, say, another example, if the patient has a seizure originating from the visual cortex, again, they will have what's called a visual aura. Okay, and they will either see things. They might say if it's originating from the primary visual cortex, they will have what elementary visual aura, where they will either have flashing lights which are colorful, uh, and they may be seen, restricted to a hemifield. Say, for example, if the seizures originate from the right occipital primary visual cortex, they might have a visual aura originating from the left visual field, and they may consist of colorful blobs, right? So, and then if as it spreads to involve the other parts of the brain, they may lose awareness, and again have various other manifestations depending on where, in which direction the seizure propagates. Okay, so I hope the concept is clear, right? So focal seizures often, if you really go into the history and how it happens, we are able to localize as to which part of the cortex is involved, and which part of the cortex is stimulated. Right? So what's the difference between focal and generalized seizures? So generalized seizures are when the seizures, they may originate from a single point in the brain, but there is rapid engagement of both hemispheres, right? And it is inconsistent. For example, a focal seizure might start from one point of the brain and then spread to involve both hemispheres, but it is always consistent. For example, if the seizure originates from the left temporal lobe and then involves the left hemisphere and then progresses onto the right hemisphere, every time the patient has a seizure, it will originate from that left temporal lobe, right? And as it spreads to the other hemisphere, then it's called that patient has, it's called to have a secondary generalized seizure or focal to tonic-clonic seizure, right? So that is a generalized seizure as a result of a focal seizure. However, the difference between the focal seizure that secondary generalizes and the seizures that are truly generalized is that there is no consistent area in which these seizures start from. So, if, for example, you can have a seizure started from the right temporal lobe, the next seizure might start from the left frontal lobe, or it might start from the following seizure might start from the left occipital lobe or the right occipital lobe. So there is no consistent site in which the seizures originate from. It can start from any part of the brain, right? But what's important is there is rapid engagement of both hemispheres. So the difference between a focal to tonic-clonic seizures is that they often, not often, but almost always start from one point of the brain, and that is consistent. Whereas in generalized seizures, there is no, we can't pinpoint one area in which these seizures start from. I hope you understood the concept, right? And an example for the best example for a generalized seizure is a generalized tonic-clonic seizure. You need to know about and this is the seizure that often most people identify with because they know they've seen these kind of seizures before. However, the generalized tonic-clonic seizures, you need to know what they look like and sound like. Why? Because these often can be misdiagnosed. So they are not seen in the majority. It's actually seen in approximately 10% of patients with epilepsy. So they're not actually the most common type of seizure that patients with epilepsy have. However, these are the ones that are dramatic, and that's why a lot of people are aware of this. So you have this tonic phase where the patients, there's an increase in the tone, right? There's a stiff cry. the patient stiffens and there is and cries out wide, and that's called a ictal cry. Okay, why does that happen? What happens is the upper part of the airway, including the glottis, there is an increase in tone, and also increase in tone of the diaphragm. And because of the increasing tone of the diaphragm pushes the air against a partially closed glottis, and that's what causes the ictal cry. It's a very distinct ictal cry, and you need to ask for it because that often predicts that this patient may have a true seizure. Okay, then of course the patient, as there is increased tone throughout the body, the patient might bear down on the tongue, and that can cause a tongue bite. And the stereotypical site of the tongue which is bitten, which the part of the tongue that is bitten is the lateral aspect of the tongue. So you need to ask for a lateral tongue bite. Okay, and then as the whole body stiffens up, there's also the patient stops breathing, so there's apnea, and as there is apnea, there is less oxygen entering the blood, and therefore there is increased deoxygenated blood, right? Because there is less oxygen entering the blood, and therefore patient becomes cyanosed, right? There is also an increase in autonomic function output, and there is an increased heart rate and an elevation in the blood pressure during the tonic phase. As there is the swallowing mechanism is affected, there is a pooling of saliva, and that's why we often note patients with epilepsy with generalized tonic-clonic seizures. We see them froth because of the pooling of the saliva. Okay, and then once the tonic phase ends, which might take a few seconds to resolve, then it goes on to the clonic phase, where there is intermittent clonic activity of the muscles, where the increased tone is briefly relaxed, and then there is what we call an acceleration phase and then a deceleration phase, right? So the clonic movements accelerate, increase in frequency, plateaus, and then decelerates, reduces in frequency as the clonic phase ends. And then there is what is complete hypotonia of the whole body once clonic phase ends, right? And that's when, if the patient had a full bladder, that's when because of the reduction in tone in almost all the muscles, including the sphincters, you will have both urinary and bowel incontinence, right? And that's when you're highly likely to aspirate, right? Because during the tonic phase, the upper airway, the glottis is closed, right? Because there is increased tone. But what happens during the clonic phase, at the end of the clonic phase, there is complete hypotonia, and that's when the gastric juices and anything that can go up, it can go through the glottis and cause aspiration, and you need to be aware of that when you are treating these patients. Okay, and then you have the post-ictal phase, where the patient is often drowsy, confused, takes several minutes to recover. There is this confusion where they are not able to they're not oriented in time, place, and person for a significant amount of time, and then slowly there is recovery of the level of consciousness. And then often they have a headache, and then they go to sleep. Often they feel drowsy, right? So if you know the phases of a generalized tonic-clonic seizure, then when you obtain the history, it's important for you to ask these components. Why is it important? That is because they often generalized tonic-clonic seizures in clinical practice is often misdiagnosed, and patients who have been diagnosed with seizures are actually having something else, and they have been erroneously started on anti-epileptic drugs. The commonest differential diagnosis that we encounter in clinical practice are psychogenic non-epileptic attacks, right? And also physiological disorders which mimic um, uh, seizures, right? The commonest one is that of syncope, right? And these are the physiological non-epileptic seizures. Non-epileptic mimics and psychogenic spells, right? So this is a list of which syncope is the commonest cause of misdiagnosis of patients with epilepsy. Right? So this is the list. You can. I'm not going to go through all this. Right. We'll talk about a little bit about non-epileptic seizures. Right. They can be as prevalent as much as 20%. So patients, if we see 100 patients, 20 will have non-epileptic seizures, and you need to be on the lookout for these patients with non-epileptic seizures, because starting them on anti-epileptic drugs is not the way to go, right? And they are often refracted to anti-epileptic drugs, right? Because obviously the anti-epileptic drugs are not going to work, and it is not as a result of abnormal electrical activity in the brain. Okay, so how do we know? It's through taking a detailed history. Now, you must understand that the diagnosis of epilepsy is based on history, and history. Right? There's no other test in the world that can either confirm or refute that diagnosis, and therefore you need to take time. You need to take history not only from the patient who has come with the seizure. You also need to take a collateral history from a person who has actually witnessed the attack, or an eyewitness account. Okay, so you need both sets of data or information for you to gauge whether you're dealing with a true seizure or not. Okay, so there are certain types of movements such as pelvic thrusting, arching of the back, or opistotonic posturing, the eye closure during a seizure, side to side movements of the head, all of which are features which may actually focus away from true seizures, and they may give you an idea as to whether these are non-epileptic seizures or not. So those are the things that you generally ask. Right? The other thing is, often nearly 99% of all seizures end or within 2 minutes. Right? So there are very few seizures that go on for more than 2 minutes, and if they do go on, it's more likely that they are in status epilepticus, right? If the patient goes on and on and on, the seizures go on and on for hours, the more likely and does not have a significant neurological deficits, then the most likely diagnosis is that the patient has a non-epileptic seizure. So the other thing is, these non-epileptic seizures wax and wane. They increase in frequency, then they go down in frequency, go up again. So there is a waxing and waning pattern, which again sort of gives you the idea that this may be non-epileptic. The other component is, often these patients who experience these non-epileptic seizures are very emotional after the seizure. So if they start crying after a seizure, most likely you're dealing with a non-epileptic seizure. Of course, these are not absolutes, right? Nothing in clinical medicine is absolute, right? They may these features may give you an idea that you may be dealing with a non-epileptic seizure. So again, these are the features. Ictal stuttering, if there is a if the patient has other comorbidities like depression, anxiety, fibromyalgia, chronic pain syndromes, if the patient has been sexually abused, um, in that context, you may think of the possibility of the patient having a non-epileptic seizure. However, you must be very wary of giving that diagnosis because even true seizures, say for example temporal lobe seizures, there is this association of depression and anxiety associated with these seizures as well. So just because a patient has depression, just because the patient has a psychiatric comorbidity does not always mean that the patient has is experiencing non-epileptic seizure. So you need to be very careful. So it's very important for you to get a detailed history of what the seizures look like. Or even sometimes what we do as clinicians is that we tell these patients to actually video the event, and then we review the video of the event to decide whether these are true seizures or not. Okay, so even a home video might be helpful in making a diagnosis, a positive diagnosis of either non-epileptic seizure or a true seizure. Okay. The other seizure mimic, which is the most, which is very common and commonly misdiagnosed, is syncope. Syncope has so for example, if the patient comes with diaphoresis, right, prior to the event, has blurred vision, or the patient says that the world went suddenly black, right, and then subsequently lost consciousness for a few seconds, and then recovery was very quick, right, you're more likely dealing with a syncopal attack. And then also you need to consider the context in which the patient experienced this episode. For example, if the patient has been dehydrated, has not taken meals, has been standing for a long period of time, and then suddenly loses consciousness for a few seconds, recovers very rapidly, most likely you're dealing with a syncopal episode or a vasovagal syncope. The problem that a lot of people encounter is that when you lose consciousness, when these patients lose consciousness, there can be some myoclonic jerks, right, where there is short duration jerks of the limbs. There can be increased tone in the limbs, right, and that is often mistaken to be a seizure because they can mimic what looks like a seizure, right? So you need to be very, very careful when making a diagnosis of a seizure. If the recovery is very rapid, because if the procedure was a true seizure, recovery is very slow, right? But if the recovery is very rapid and orientation is very rapid, where the patient is able to identify things around him or her and identify where they are very, very quickly, then you're most likely dealing with a syncopal attack. Okay. Often what happens in syncope is that the patient is often, they're not cyanosed, right? They become pale. That's because there is less blood going into the cutaneous tissues, and therefore they become pale as opposed to cyanosed, where you would have during a generalized seizure where there is increased deoxygenated blood. That is not the case in a patient with syncope, right? So there is the patient is much more pale and is more flaccid than in a patient with a true seizure. However, you must always be aware that because of the activation of the reticular formation, you might have myoclonic jerks, increased tone, and even certain cases can mimic these complex motor movements such as automatisms um, with these with syncope. Okay, so what happened before the event is very important. For example, there have been patients yesterday or day before I saw a patient. The patient has seen blood, right, while having a cut injury, and then subsequently had some blurred vision and then fell down, right, and there was increased tone. And then a few seconds later, recovered completely. There's no post-ictal drowsiness or headache. Patient was diagnosed as having a generalized seizure, right, and was started on antiepileptic drugs. But this was what we call a situational syncope. Some people can't see, when they see blood, they feel that like as if they're going to faint. Okay, so a simple faint is almost always misdiagnosed, right? Okay. Okay, there's a question. So could you please clarify if the non-epileptic seizures are as the same as psychogenic non-epileptic attacks, right? So non-epileptic seizures are these days synonymous. We use that the term interchangeably, and there is always a we use the psychogenic um, or PNEA nomenclature, but that is a nomenclature which we used to use those days. Nowadays, what we use is the word non-epileptic attack disorder, or NEAD. Okay, but it is more or less synonymous. Okay.
So excuse me.
Yeah.
So in that case, sir, is that a true seizure? That it may not be epilepsy, but is that a seizure, sir? Those kind of spells.
Yeah. So now, what they are not now. See, by definition, what is a seizure? Now, what did I tell you? A seizure is the first slide that I showed you. Seizure and epilepsy. What is the seizure?
It is a set of clinical symptoms that are caused by abnormal electrical activity of the brain.
Right. Absolutely right. Correct. But in these patients, there is no abnormal electrical activity, right? So they are by definition not seizures, but they are events that mimic seizures. So they
Okay,
have
sir.
been
Okay.
coined as non-epileptic attack disorder, NEAD, but they have that's why. So the nomenclature is a bit confusing. So they've been also coined as psychogenic non-epileptic seizures as well, or PNES, right? But they are not true seizures.
Okay, sir. Okay.
But the thing is, now a lot of people think that this is, that the patient is putting it on, right? And they are berated on, the fact that they may be putting it on. But often in the majority of patients, they are actually not putting it on. It's actually a maladapted coping system. And in more than 50% of patients, we really don't know why they get it. Right? However, the most important thing is not to put them on long-term anti-epileptic drugs, which can cause more harm than good. Okay.
Okay, sir. Okay, sir. Thank you, sir. I understand.
Okay. So that's on syncope. And sorry, are these seizures or seizure mimics? So now these, that's another question. So they are actual seizure mimics. So that's why it's important for us to identify what a seizure is as opposed to a seizure mimic, because the treatment is completely different. So can we start AEDs for situational syncope? Situational syncope. So again, going back to the definition, seizure is a result of abnormal electrical activity in the brain. So a drug that we use to suppress seizures actually suppresses that abdominal electrical activity. What is situational syncope? You see, say for example, if you are either standing for a long period of time, or if you're dehydrated, or if you see some thing that is that causes you you know outflow of emotion, that causes the vagal nerve to inhibit the nerve, or an inhibitory effect on the heart, where there is a reduction in cardiac output as a result of a reduction in the heart rate. Okay, and then what happens? There is less blood going into the brain. Okay, and as a result, reflexly the patient falls down, right? And as soon as the patient falls down, the venous return increases and the cardiac output increases, and there is re-establishment of the blood supply to the brain. So do you think starting an anti-epileptic drug in those patients would help? Whoever asked the question.
No, sir.
No, exactly. Right? So that's why it's important for us to identify true seizures from syncope, right? Because the pathophysiology is completely different. I hope you understood that. Yes?
Yeah, thank you, sir. Sir, then the girl who fainted at the sight of blood, is it also a situation syncope?
Yes. Because what happened? The emotional component there is she felt some people can't they're not tolerant at the sight of blood, and then what happens is again there is vasovagal syncope, where there is activation of the vagal nerve, heart rate goes down, same sort of pathophysiology, and the blood uh, to the brain reduces, and then patient falls down. Same thing. Yeah. Then there is also certain types of. Has anyone heard about micturition syncope, where there is blood outflow obstruction due to benign prostate hypertrophy, or where the patient has lower urinary tract symptoms? They are again because of the vagal stimulation, the patient loses consciousness. Again, situational syncope. So the patient will come telling you that, every time I go to the toilet, I lose consciousness, right? And if you ask for a detailed history, patient says, and every time he or she, sorry, he, not she, but he urinates, patient loses consciousness. That's micturition syncope. If a patient has cough, nagging cough, coughs and coughs and coughs and coughs, that causes again the same pathophysiology, vagal stimulation. So that's called cough syncope. Okay, so those are all situational syncopes. So often misdiagnosed. There are patients who have been referred to the neurologist with cough, and the patient loses consciousness to see, and misdiagnosed as having epilepsy. To see, you treat the cough, the syncope goes away. Okay, understood? Yes.
Yeah, sir. Thank you.
Okay. All right. So that's on syncope, right? You do also, yeah. So it's syncope can be vasovagal syncope also. Syncope can be as a result of cardiac arrhythmias as well. So you need to be very, very careful. For example, there are a few patients who were referred to neurology some time back. They used to lose consciousness very quickly, rapid recovery. So that told us that we weren't dealing with epilepsy, because the recovery was that quick. And then patient was referred for cardiac monitoring to find out that these patients were having episodic ventricular tachycardias. And then what was done was they were implanted, the cardiac defibrillator was intracardiac defibrillator was implanted, and they didn't have any further episodes. So it's important for you to differentiate the two. Okay. Then a little bit about epilepsy syndrome. So now what's a syndrome? A syndrome is defined as a collection of common clinical characteristics or any features that are common to a certain group of patients, right? We put them into a bunch and then we call it a syndrome. No? And in epilepsy, the syndromes are based on one, their seizure type, age of onset, if there's a family history, EEG, typical EEG findings, any other diagnostic investigations, treatment, and the prognosis, right? Can anyone give me an example for a childhood epileptic syndrome that anyone knows? Very common. Since I'm dealing with adult, anyone with just an example? Has anyone done pediatric epilepsy? Not yet.
No, sir. We just had the classification and introduction lectures.
Juvenile absence.
Yeah, so juvenile absence is a epileptic syndrome. That's absolutely true, which I will deal with. That is a adult epilepsy syndrome, which comes on during adolescence. Absolutely true. Of course, a very common epilepsy syndrome that a lot of people know of, if you have done a pediatric appointment, is childhood absence epilepsy. All right. There you have a typical seizure type, which is an absence seizure, which is again an example for a generalized seizure. You have the typical age of onset, generally 5 or 6 or between 4 and 6 years of age, depending on the gender. And then there is spontaneous regression of the seizures by the teenage years, right? And also you have a typical EEG pattern, which is called 3 Hertz spike and wave pattern. So I hope you understood the concept. So if they have a typical seizure type, typical age of onset, right? If typical EEG findings, which are common to a group of patients, then we class them as them having an epileptic syndrome. Okay, and the typical epileptic syndromes that we deal with in adults are this list of epileptic syndromes, of which I'm not going to speak about progressive myoclonic epilepsy, nor am I going to speak about autosomal dominant epilepsy with auditory features or ADAF and other familiar temporal lobe epilepsies. The first three are the most common epileptic syndromes that we deal with in adulthood. Okay, so that's juvenile absence epilepsy, juvenile myoclonic epilepsy, and epilepsy with generalized tonic-clonic seizures alone. And now they are actually, these three actually called, they're coined as idiopathic generalized epilepsies or genetic generalized epilepsy because they have a genetic basis. Right, so we'll talk a little bit about juvenile myoclonic epilepsy. It's again genetically it's a determined generalized epilepsy. Why do we call it a generalized epilepsy? Because there's all the seizure types, they have 3 seizure types. All of them are of generalized onset. So if you remember the ILA classification, if you remember that the seizures are generally classified into focal onset, generalized onset, and unknown onset. So these seizures in this particular epilepsy syndrome are all generalized seizures. And the predominant seizure type, right, is that of a myoclonic seizure, right? So the myoclonic seizure is the predominant seizure type in juvenile myoclonic epilepsy. And of course, you can have very infrequent generalized tonic-clonic seizures as well as typical absence seizures, but they are the minority. So the major seizure type is that of myoclonic jerk. Right? And typically the age of onset is during the teenage years. Of course, it's a wide range between 8 to 26 years. However, the majority will be between 12 and 18 years of age. They have a typical EEG pattern. You don't really need to know this, but they have what's called a 3 to 6 hertz generalized polyspike and wave discharge pattern. So once, even based on the EEG, we are able to diagnose these patients as having juvenile myoclonic epilepsy. So it's that characteristic. Treatment is, we've got a number of anti-epileptic drugs, and of which valproate, levetiracetam, lamotrigine, clonazepam are the AEDs of choice. Okay. Prognosis, the patient needs long-term or lifelong anti-epileptic drugs. So that's why it's important for you to diagnose this syndrome, right? So you know, if the patient comes with myoclonic jerks, if the patient is within the teenage age group, if the EEG is characteristic of juvenile myoclonic epilepsy, then you know that these are the drugs that are effective for this particular syndrome, and also you know that these drugs need to be continued, until late adulthood or until the patient goes to, it should be lifelong. Okay, at least should be continued until the 4th decade of life. So I hope you understood why it's important for us to diagnose this epilepsy syndrome. So it has bearing on treatment and management. Yeah, and more importantly, there are certain anti-epileptic drugs that actually make this epilepsy syndrome worse. For example, carbamazepine, phenytoin, pregabalin, gabapentin, anti-epileptic drug, vigabatrin, all of them are actually contraindicated in this type of epilepsy and can make things worse. And in childhood, especially, if the seizures such as childhood absence epilepsy, the absence seizures are misdiagnosed to be of a different type of seizure, and they are started on carbamazepine, they can go into what's called an absence status. Then they may have continuous seizures throughout, mainly because of the drug. So it's important for you to differentiate or try to diagnose these patients and class them into an epilepsy syndrome. Juvenile absence epilepsy, again, very similar to that of the juvenile myoclonic epilepsy. However, the predominant seizure type, again, is the absence seizures, where they stare for a few seconds and then they recover very quickly. And this is the predominant seizure type. And how is it different from childhood absence epilepsy? One is that the age of onset is not during childhood, but during adolescence. You have more occurrence of generalized tonic-clonic seizures compared to that of childhood absence epilepsy. And again, this patient they may need to be on long-term anti-epileptic drugs. Okay, and what you should know is that about 80% achieve complete control. However, 20% may be intractable. Right. Right. We're not talking about autosomal dominant partial epileptic coordinatory features. You can go through the slide from the LMS. Now, I'm not going to talk to you about progressive myoclonic epilepsy. It's unlikely that you will be tested on these epilepsy syndromes simply because they are very, very, very rare. Okay. Right. Okay. So we spoke about juvenile myoclonic epilepsy, juvenile absence epilepsy, and also what I didn't speak about is epilepsy with generalized tonic-clonic seizures alone. It's very similar, but as the nomenclature suggests, they only have generalized tonic-clonic seizures. They do not have the other types of seizures, such as myoclonic absence seizures. Okay, but so those are all what we call genetic generalized epilepsies. Almost all of these genetic generalized epilepsies, carbamazepine, phenytoin, pregabalin, gabapentin, and vigabatrin, all those are contraindicated. So they can make seizures worse. Okay, so you need to understand why we try to put them into these syndromes, because they have direct bearing to the management of epilepsy. Etiology. We spoke about, so the epilepsy syndromes are often genetic. There are other etiologies that we need to consider. Head trauma, drug intoxication and withdrawal in adolescents and young adults are major cause of seizures and epilepsy. In old adults, again, stroke, brain tumors, neurodegenerative disorders such as Alzheimer's, Lewy body dementia, spectrum of dementias can give rise to seizures as well as epilepsy, and acute metabolic disturbances again can give rise to seizures more likely than epilepsy. Okay, so those are the common sort of etiologies that we generally consider. Head injury, okay, it's very important. So the severity of the injury predicts the likelihood of the patient getting epilepsy later on, right? So if the head injury included brain contusion, intracranial hematoma, or post-traumatic amnesia of more than 24 hours, they are more likely to get epilepsy as time progresses. Moderate injuries such as skull fractures and post-traumatic amnesia of more than 30 minutes, less than 24 hours, again, they have moderate risk, and low risk ones are mild injuries where there aren't any fractures, and post-traumatic amnesia is limited to less than 30 minutes. I'm sorry, there is another question. So what determines the nature of the motor manifestation of a seizure as tonic or clonic or myoclonic, right? Yeah, that's a very interesting question. We really don't know, but it's the different parts of, or the seizure generators. There are various seizure generators in the brain. For example, for absence seizures, what is postulated is that there are what we call T cells or within the thalamus, right? And they are the cells that are mainly involved in calcium cells, calcium T cells, which are involved in the pathophysiology of absence seizures. Okay, so if that is the main, so it's the seizure generator, right, in the brain that results in the semiology of generalized seizures. Okay, so various seizure generators are there within the hemisphere or within the brain, and depending on which is involved, then the patient will have either tonic seizure, atonic seizure, or an absence seizure. For example, now for an atonic seizure, so I told you about absence seizures, which is the thalamus that is involved. For atonic seizures, there are what we call negative motor areas in the brain, right? This is very advanced epilepsy. Say if the inferior frontal gyrus of the frontal lobe as well as the mesial frontal lobe is affected bilaterally, then the patient can have what's called an atonic seizure. Okay, so it depends on which part of the brain is involved again, but again it has to be rapid engagement of both hemispheres have to be involved for it to be a generalized seizure. I hope that answers your question.
Yes, sir. Thank you. Thank you, sir.
Yeah. Okay. Right. So next slide. So the severity of the head injury also has an impact on seizures. Okay. Right. Sorry, we're not going to go through tumors. Right. Okay. So diagnostic studies. What are the investigations that we would generally do when encountering a patient with a seizure or a seizure syndrome or epilepsy syndrome? Is that we would generally do a blood work, which includes electrolytes, calcium, glucose. Does anyone know why? Why do we do this?
To exclude hyperglycemia and
Yeah, so to differentiate what type of seizure. What are you really looking for?
between provoked and unprovoked seizure.
Yeah, exactly, absolutely. So we are doing this blood work to differentiate whether this is a provoked seizure or an unprovoked seizure. Why do we do that? Why do we need to differentiate between a provoked and an unprovoked seizure?
Because if it's a provoked seizure, we can reverse the fact and
Exactly. You reverse the electrolyte imbalance, or you change, or you correct the mainly it's hypocalcemia. If you change or correct the hypocalcemia, or you change or correct the hypoglycemia, the patient is not going to have any seizures. And do these patients need long-term antiepileptic drugs to suppress seizures? Yes or no?
No, sir.
No, exactly, because it's completely correctable. Urine toxicology, why is that important? Of course, not in everyone, but in certain instances where you think that the patient has overdosed on on a toxin. Why? Why is it important? Urine toxicology? Anyone?
Some toxins also can provoke the seizures.
Exactly. So you're again looking for a provoked seizure, right? So why is that important? We don't put them on long-term antiepileptic drugs. What we do is we give the antidote, antidote, and then the patients don't get any seizures. Right. So EEG very important, because if the patient gets a seizure, the EEG is very important in trying to not for the diagnosis of a seizure, because the EEG is of how do you diagnose seizures? It's mainly based on history, nothing else. But the EEG does a few things. One is it helps you to so if a patient comes with a single seizure, it helps you to risk stratify. It helps you to predict if the patient is going to have more seizures in the future, right? So EEG abnormalities are associated with a higher risk of seizure recurrence, right? So for example, if you have a generalized epileptiform discharge on your EEG, you're more likely, even after a single seizure, you're more likely to have more seizures which are unprovoked in the future. So those patients are at a higher risk, and you may start them on antiepileptic drugs, right? So in that essence, the EEG is very important. The other important thing with regards to EEG is you're able to classify them into a certain syndrome based on the EEG characteristics. For example, if the patient has a typical myoclonic seizures, you do the EEG has an EEG which is very typical of that of a juvenile myoclonic epilepsy. You diagnose a syndrome, and then you know exactly what the prognosis is going to be. You know exactly what the antiepileptic drugs are going to be for the patient. Okay, so that's why it's important. But the more important thing is what a lot of people don't understand is that EEG is not a tool we use to diagnose whether this patient has epilepsy or seizures. What do we use it for? It is a added tool. It's not a tool that we use to confirm our diagnosis, right? And abnormal EEGs are uh, excuse me, sorry. Oh, hello. Hello. Okay. Oh, oh, 7:30. Oh, huh? මේ සැටේ නෑ මම. ඊළඟ සැටේෙත් නෑ මම. ඊළඟ සැටේෙත් නෑ. ඒ වීකෙන්ඩ් එක නෑ මම. 13 14th. ඒ වීකෙන්ඩ් එක නෑ. Okay, thank you. Sorry. Yeah, so what you should know is that more than 50% of EEGs, even if the patient has had a true seizure, can be normal, right? So a normal EEG does not exclude the diagnosis of epilepsy or a seizure syndrome. Okay, so that's very important. We use ambulatory EEG and video telemetry. That's where the patient is fitted onto a EEG cap, and then the patient is free to move for the next 24 to 48 hours, and we record the EEG continuously, right? And that's again a tool that we use when we are really not sure whether we are dealing with true seizures or whether the patient is experiencing non-epileptic seizures or not. So ambulatory EEG is an important test that we do. It's not widely available in Sri Lanka, and it's expensive. Therefore, I don't think it is a tool that will replace the best tool to detect seizures, and that's taking a good history. Video telemetry again used for confirmation of whether these patients have the true seizures or not, and also it's used as a tool to identify from which portion of the brain the seizures are coming from, or trying to find the source. And that's very important, especially in patients that are refractory to anti-epileptic drugs. And you should know that not all patients are amenable to pharmacotherapy. And the proportion of patients that are treatment who respond to treatment are actually 70%, whereas 30% actually are pharmacoresistant and do not respond to anti-epileptic drugs. And those particular patients are actually evaluated for other alternative treatment options, which includes surgery. And there are patients who we do surgery, who we think that the seizures originate from a single focus in the brain. And we remove that focus, which is called epileptogenic focus. And for that particular purpose, video telemetry or video EEG is very important, a very important test. And what do we do in video EEG? What we do is we record the seizure in front of a camera or a video, and we concurrently we record the EEG as well. And while the patient is having the seizure, we see the EEG changes and try to see whether we can find out from which part of the brain the abnormal electrical activity is coming from. Imaging study is very important with regards to identifying a focus or etiology. In this country, CT brains are generally it's easily available, and I would suggest any patient who has a seizure which is adult in onset, you need to image these patients. Why? Why do we need to image it? Why is that if a patient has a single seizure, right, and your imaging suggests that there is a structural lesion which is attributable to that particular seizure, the patient has a higher risk of developing seizures subsequently. Okay, and that's why it's important for you to image the patient. So risk stratify the possibility of further seizures occurring. And if you can remember the first few slides, our definition encompasses the definition of epilepsy also takes into consideration the fact that the patient may have a single seizure, and if you find that the risk of further recurrence is more than 60% is over the next 10 years, your patient may be diagnosed as epilepsy. For that particular purpose, the imaging is very important. And if you find that the patient has abnormal imaging, then you're more likely to be dealing with a patient with epilepsy. Of course, that seizure should be attributable to that particular insight that you see on the imaging. So ideally, these patients should undergo MRI, but brain MRIs are not freely available. Of course, in most hospitals in the country, around the country, a CT is available, and therefore, any adult onset epilepsy, unless it's a clear cut syndromic diagnosis should undergo imaging, neuroimaging, and of which MRI is the best. The MR imaging is able to sort of detect even the slightest scars in the brain that can be attributable to that particular patient's epilepsy. I'm not talking about PET scanning today. Then, of course, we have to talk about the treatment decisions. Now, not everyone with seizures have epilepsy, right? Are going to have recurrent seizures. You must understand that if you nearly 10% of the population will have a single seizure throughout their life, right? Out of which only, so out of the 10%, and then subsequently 2 to 3, only 2 to 3% of patients will have recurring seizures or what we call epilepsy. So majority of patients with a single seizure will not have seizures subsequently. And why it's important for us to understand that, because that particular cohort of patients, we will not need long-term anti-epileptic drugs. And that's why it's important for us to risk stratify these patients and try to predict the possibility of having further seizures. And that's why imaging is important. That's why the EEG is important, because they are the patients who, if they are abnormal, they are more likely to have more and more seizures, right? So treatment decisions are, you need to, in that particular cohort of patients, you have to decide whether the risk of, you have to decide the risk of subsequent seizures versus the risk of treatment, and also take into consideration the particular circumstances of the patient as well. So what we, now the risk of treatment, what we give as anti-epileptic drugs are not completely benign, right? So they can be, they can cause disastrous side effects. For example, can someone tell me a very severe side effect of carbamazepine? Anyone?
Leukopenia.
Sorry?
Leukopenia.
Leukopenia. So carbamazepine actually can cause bone marrow suppression, but there is a skin condition called Stevens-Johnson syndrome or toxic epidermal necrosis, in which the patient can actually die. And if you start them on carbamazepine, certain patients can have this severe skin reaction, and which with dire consequences. So that's just an example of what we, so anti-epileptic drugs are not really completely benign. It can affect quality of life of that particular patient, right? So you need to weigh the risks versus the benefits of starting anti-epileptic drugs, and and you have to risk stratify these patients in which you need to decide, okay, so this patient is going to have a higher risk of seizure recurrence, and this is why we are going to start anti-epileptic drugs on this patient. Also, certain circumstances, for example, if it's a patient who deals with heavy machinery and doesn't really want another seizure, right, and can't risk of having, cannot afford to have another seizure, then again you might start these patients on anti-epileptic drugs, right? So the special circumstances of the patient also needs to be considered when you're starting anti-epileptic drugs. You need to simplify treatment. It should be monotherapy and not polytherapy when you start the patient on anti-epileptic drugs. You should start on a low dose, titrate to the dose that is thought to be efficacious, and look out for side effects. And if you are converting from monotherapy to polytherapy, you need to eliminate sedative drugs first and withdraw anti-epileptic drugs slowly over several months if you are converting into from monotherapy to polytherapy. These are this slide is a busy slide. You don't really need to, what I need to sort of emphasize on this slide is one is that for each seizure type, there are effective anti-epileptic drugs. Can you see that? So myoclonic epilepsy, for example, the first line drugs are levetiracetam and sodium valproate. And as you can see, and I've alluded to this before, is that certain drugs are contraindicated, drugs to be avoided. That's carbamazepine, gabapentin, oxcarbazepine, phenytoin. So there's a list of drugs which cannot be used for myoclonic epilepsy. Same concept when it comes to Addison's epilepsy. It's more or less the same list of drugs. However, it's important for you to understand that certain drugs can make certain seizures worse, right? And you need to know which drug is effective for which type of seizure. And that's why it's important, if you remember, one of the first few slides that I shared with you was the ILA classification of seizure types, right? So it's important for you to classify the seizure type. And why is that important? It's because it has direct bearing on the drug we choose for that particular patient, right? So that's what I wanted to highlight in that. And on this slide, what I need to highlight is that you need to know the common side effects of the common drugs that we use. For example, carbamazepine, rash is not common, but can be a severe side effect and cause what's called Stevens-Johnson syndrome. Diplopia, dizziness, headache, almost all the anti-epileptic drugs will cause reduction in cognition, slow your cognition down by around 25%, and cause increased somnolence. These are the target maintenance doses that you need to be aware of. You don't really need to know these, but then as you start practicing as doctors, you will need to know it. But these will never be tested, so you'll never be asked what the maintenance dose of lamotrigine is, but you may be asked, okay, what is the commonest side effect, because you need to know the side effects before you actually prescribe a certain type of medication. Okay, so the other important aspect that you need to remember is that these drugs can also interact with other drugs, especially when you are prescribing drugs to patients with other comorbidities. So, for example, if you're prescribing patients to patients who above 50 years of age, they're more likely to have diabetes, they're more likely to have hypertension, or what we call the non-communicable diseases, and they may be on a multitude of other drugs. And you need to know that the anti-epileptic drugs can interact with those particular drugs. So the old anti-epileptic drugs such as carbamazepine, phenytoin, phenobarbital, sodium valproate are drugs which can cause multiple drug-drug interactions. So you need to know the common enzyme inducers, which are carbamazepine, phenytoin, and phenobarbital, and the common inhibitors or that inhibit metabolism. The example would be valproate, and also the ones that are highly protein bound, because any condition which can alter the protein content within the serum can also change the drug levels as well. Okay. Dose initiation, you need to discuss the likely and unlikely but important adverse effects of the drug that you're going to start on. So, for example, if a patient comes to me and I start the patient on, say, for example, lamotrigine, I will always tell them that there is a chance, 1 in 30 chance of a skin reaction occurring, and that's a very important side effect. You need to, if you see a skin rash, you need to stop the medication and then come back and see your doctor. So that piece of vital information needs to be given to the patient. Discuss the likelihood of success. As I said, approximately 70% of patients respond to anti-epileptic drugs, 30% don't. So you need to tell that to the patient that this is not 100%, right? And if they get further seizures, that may also be an expected consequence of that may be also expected. And you have to also discuss the importance of recording, reporting seizures, right? That's will have direct bearing on our management. Common side effects, as I said, all cause somnolence. Rash is commonly seen with lamotrigine, phenytoin, and phenobarbital. Renal stones in topiramate. Hyponatremia, very commonly seen with carbamazepine and oxcarbazepine. Cognitive side effects, very severe ones, are seen with phenobarbital and topiramate. Paresthesia with topiramate, and behavioral abnormalities with levetiracetam. So these are the common side effects that you may need to remember. You need to talk about lifestyle modifications such as adequate sleep, avoidance of alcohol, which are triggers of seizures, avoidance of known precipitants, for example, flashing lights, especially with genetic generalized epilepsies like juvenile myoclonic epilepsy, where photosensitivity is seen in 1/3 of patients. Flashing lights can precipitate seizures. Stress, very common. Anxiety, very common trigger for seizures, and especially during times of stress and anxiety, the seizure frequency can increase. So you need to talk about lifestyle modification. There are other treatment options apart from anti-epileptic drugs, especially in patients who fall into the category of pharmacoresistant epilepsy, of which ketogenic diet, especially in children, is a useful treatment option in which we actually reduce the carbohydrate intake and increase the fat and protein content of the diet, which has an anti-seizure effect, which in turn causes ketogenesis or ketosis. So it's a low carbohydrate, low protein, high in fat content diet. And however, most often than not, children find it difficult to tolerate this diet, and therefore there is very little data on long-term effects of ketogenic diet. Vagal nerve stimulator, not so much available in Sri Lanka, again used for patients who are again pharmacoresistant, not amenable to anti-epileptic drugs. This is something like a pacemaker, but the lead goes not into the heart but into the brain, right? Not very much really into the brain, but the vagus nerve. So a lead is attached to either left or the right vagus nerve, commonly the left. The left, and there is stimulation of the vagus nerve, which in turn aborts seizures. The mechanism of action is not very important, but just bear in mind that there is this treatment option available, not so much in Sri Lanka. And of course, epilepsy surgery available in Sri Lanka, again for patients who are pharmacoresistant, in which we are able to identify the onset of the seizure. Then we go ahead with excision, or what we call disconnection of the area which we think that the seizure starts from. Then a little bit about women with epilepsy. Why is it important for us to discuss this? Is because of this effect of epilepsy that affects so in females of childbearing age, there is this effect of the sex hormones, estrogen and progesterone, on the epilepsy, and also it has an effect on the anti-epileptic drugs that we use. And also the anti-epileptic drugs that we use can affect the sex hormones as well as the epilepsy. So there is this triangle that you can see on the slide, where each component can have a bearing on the other, right? For example, if the patient is pregnant, right, the pregnancy itself can have a bearing on seizure control. For example, in most cases there is no change in the seizure frequency, but in a certain minority of patients, approximately 15% of patients, the seizure frequency can worsen, right? But not in the majority. So that's how the pregnancy or the hormonal state can affect the epilepsy. How does the anti-epileptic drug concentrations, how does that affect the epilepsy? is that certain anti-epileptic drugs can reduce in the serum, right, and worsen seizures. The other thing that has to be taken into consideration is the teratogenic effect of the anti-epileptic drugs on the unborn fetus. So as you can see, there are certain issues that are actually confined to women that can affect both the epilepsy as well as the particular patient themselves. Right? So most pregnancy mothers with epilepsy produce normal children. However, there is an increased risk of fetal anomalies, and that can be multifactorial, especially if the patient is on certain types of anti-epileptic drugs. I'll speak about the teratogenic effect of the common anti-epileptic drugs subsequently. But what you need to know is that if the patient is on multiple anti-epileptic drugs, they have a higher risk of teratogenicity. The risk of major congenital malformations in a pregnancy is approximately 1 to 2% if the patient is not on anti-epileptic drugs. If they are on anti-epileptic drugs, generally that doubles, so it's around 2 to 3%, and there are certain anti-epileptic drugs where the malformation risk can be very, very high, as much as 10%. The highest risk is with valproate, as you can see in this slide. Right. So as you come down on in the slide, these drugs at the bottom are actually less teratogenetic: lamotrigine, oxcarbazepine, and levetiracetam. And these are the drugs that we would generally recommend if the patient is to be pregnant or is planning pregnancy, and therefore the patients who are on antiepileptic drugs should have a planned pregnancy, and the pregnancy, and therefore they need to come back to the doc and tell their pregnancy wishes prior to conception. So it's therefore we have enough time to take them off the more teratogenic drugs if they are already on it, and to start them on less teratogenic drugs. Right? I hope you understood the concept. And in other countries, valproate is a red label drug, especially in the West, especially in Europe. And we would, as much as possible, even in this country, avoid valproate, especially in the reproductive age group. And try as much as possible to avoid polytherapy, because polytherapy increases the incidence of teratogenesis, especially during the first trimester. Okay, and has the risk of major congenital malformation. Okay, so that's all I have to tell. Are there any questions? Anyone? Sorry. So can focal seizure start from the center in the brainstem and cerebellum? No, they are often from parts of the cortex or subcortical, just adjacent to the cortex. You will not see focal seizures from the brainstem and the cerebellum. So that's the question is, can focal seizures start from the center in the brainstem and cerebellum? So even generalized seizures, they have to start from gray matter. Okay, so often it's the cortex, so somewhere in the cortex. What happens is they propagate through relay stations, of which the thalamus is the biggest relay station. The thalamus and the brainstem nuclei are the biggest relay stations in the brain, and that's the one that helps in propagating it to both hemispheres. Are there focal tonic-clonic seizures? There aren't any focal tonic-clonic seizures. There are what we call focal to tonic-clonic seizures. For example, patient starts getting a seizure which is from one part of the brain and then spreads to involve both hemispheres, and that's when you call that patient to have a generalized tonic-clonic seizure as a result of a focal seizure. But there aren't any focal tonic-clonic seizures. As if you go through the ILA classification, focal seizures are divided into motor and non-motor ones. So there aren't any tonic-clonic seizures which are focal, but they can start focal. Sorry, what is this? Can protein energy malnutrition reduce seizure threshold? I suppose if there is ketosis. Sorry, the other way around. If there is ketogenesis, the chances of seizures occurring actually reduce. So it increases the seizure threshold. So fasting actually increases ketogenesis, and ketosis itself, because the substrate in the brain is changed, the major into hydroxy, butyrate, and that can reduce actually the chance of seizures. What else? Can a patient be managed on a keto diet instead of AEDs if the patient wishes to? No, the ketogenic diet is always an adjunct treatment, right? And it has to be combined with anti-epileptic drugs. So ketogenic diet alone is not recommended. So can protein energy, I answered that question. So can you please describe ketogenic diet more? So generally so whatever that is there on the internet, if you want to lose weight, what do? You eliminate carbohydrate intake, right? The carbohydrates are the ones that actually increase the likelihood of fat deposition and so on and so forth. What the ketogenic diet does is it nearly completely eliminates the carbohydrate component, which is approximately 60-70% of most of our diet. Correct? So what it does is the food pyramid is inverted, right? And that in turn causes ketogenesis. And the ketogenesis itself it actually reduces the likelihood of seizures occurring, because the energy substrate for the brain actually changes. It bypasses the glucose metabolism. And that's what happens. Hope you understood that. Okay. I'm sorry, what is the other one? How can we decide whether the patient is resolved from epilepsy? So I didn't talk about resolution of epilepsy. So if the patient has been off anti-epileptic drugs for 5 years and has been seizure-free for 10 years, then we say that the patient has his epilepsy has resolved. So there is a definition for that, right? So that's the definition of resolved epilepsy. So if the patient is off anti-epileptic drugs for 5 years and has been seizure-free for 10 years, right? Then we say that the patient has no epilepsy, or his epilepsy has resolved. So that is the definition. What else? So is there a likelihood of developing seizures in a sleep-deprived patient? Yes. So there are certain types of epilepsies that are activated through sleep, right? And sleep deprivation, not sleep, but through arousal. Okay. And so patients who are sleep deprived are more likely to be tired, more likely to reduce the seizure threshold, and therefore are more likely to have more seizures. So what we do is we often tell our patients to have a good night's sleep. Okay, so that answers that question. Sorry, there's some more. Why there is no mention about status epilepticus? I'm sorry, so that's a different topic altogether. I don't think 1 hour is enough to start on status epilepticus. So status epilepticus, there are various types of status. One is focal status and the other one is generalized status epilepticus. So focal, so definition for status epilepticus is different. And if you have ongoing seizures for more than 5 minutes, if it is a generalized seizure, that's the patient is having generalized status epilepticus. However, if the patient has a focal seizure and the seizure goes on for more than 10 minutes, the patient is supposed to be in focal status. Now, there are two definitions. One is, when do we call these time definition? Two timelines. There is what we call T1 and T2. The first definition for T1, or when do we call these patients as having status, is the one that I just mentioned to you. Then there is also another time, or the second timeline is where there is permanent neuronal damage. And so if it's a generalized seizure, and if the seizures go on for more than 30 minutes or more, you're more likely to have permanent damage to your brain. Okay. So why do we have two thresholds, two time thresholds? Is that what the data shows is that if the patient has a seizure for more than 5 minutes, the chances are that their seizures will go on for more than 30 minutes, and that will result in permanent cerebral dysfunction or permanent brain damage as a result of ongoing seizures. So that's why we have two timelines or time thresholds. For focal seizures, it's actually 10 minutes. If the patient goes on for more than 10 minutes, more likely that the patient will have focal seizures which will go on for more than an hour. And the hour is the second time. Hello. lecture half an hour again. Sorry. Yeah, so I hope that is that takes care of the definition of status epilepticus, but status is a different topic altogether, and I don't think I have enough time to sort of deal with status. Sir, is aura comes only before focal epilepsy? Can't aura precede generalized epilepsy? So it's yes. The aura is a manifestation of a focal onset epilepsy, right? So if you say, for example, if the epilepsy starts from the visual cortex, they will have a visual aura. If it starts from the sensory cortex, they will have a sensory aura, so on and so forth, right? So they can have an aura which is preceded or which proceeds to a generalized tonic-clonic seizure. But this aura is often, if you ask the patient whether you remember the aura, the patient will not remember, because when the generalized tonic-clonic seizure occurs, it spreads to most of the brain, and simply because of the propagation, the patient will not remember the aura, right? And if they do remember the aura, it's unlikely that the patient has either had a generalized tonic-clonic seizure, or if the patient remembers something like an aura, it's more likely that the patient has had. So there is a prodrome also in seizures. They may feel. A lot of patients have what's called a premonition that they're going to have a seizure, and that can happen over a day or so. They may actually describe that, but if a patient has had a generalized tonic-clonic seizure, it's unlikely that they will remember the aura. They can have an aura, but that is a focal seizure, which then spreads to become a generalized tonic-clonic seizure, but that's called a secondary generalized seizure or focal to tonic-clonic seizure. I hope that answers that question. Lots of questions. How can, sorry. Can't aura proceed? Yeah, I answered that question. Do physical activity and dehydration increase risk of seizures? Physical activity, probably not. But if the patient is very tired, especially mentally tired, patient can have an increased risk of seizures. So it's a very individual thing, this trigger, right? So certain triggers are, if can be very, very individual or individualized or restricted to that particular individual. So I can't say no, but physical activity itself per se is not a cause for seizures or a trigger for seizures. Is existence of aura can only be known by patient's words, or are there any investigations available we can do? No. So it's again, we have to take the patient's word for it. So that's why it's called an aura, because it's experiential in the sense it's what the patient experiences, and therefore it's the history that will that you will need to take. And it's very important, especially when in what we do, when we are actually trying to localize these, localize and lateralize these seizures. It's it's very important, especially in patients that we are considering surgery, because when we analyze the seizures and say, for example, if they say that they have an aura of fear, that itself actually localizes the seizure to the amygdala. And when we are actually evaluating these patients for epilepsy surgery, we look at the amygdala on imaging to see if there are any abnormalities, and if there are any abnormalities, we would generally resect that part of the brain to render this patient seizure free. So analysis of the aura is very important, but there is no test that will confirm or refute that. So as I said, epilepsy is based on history taking. So existence of an aura can only be known by, yeah, okay, right, okay. Anything else? Right, okay. Since there aren't any questions, let's stop for today. Thank you very much.
Thank you, sir.
Thank you.
Thank you, sir.